Hello, my name is Marissa Beasley, and I am currently an RN in the postpartum department of labor and delivery. My PCOT question is, for women laboring in a hospital, does the use of quantitative blood loss reduce the risk of postpartum hemorrhage compared to the current use of estimated blood loss after delivery? The reason why I chose this topic is because I work in labor and delivery, and we deal with postpartum hemorrhage patients more often than we would like. Per the Association of Women's Health Obstetric and Neonatal Nurses, or AWON, the United States is 47th in the world in maternal morbidity, with obstetric hemorrhage being the leading cause of maternal morbidity. 125,000 women per year suffer an obstetric hemorrhage after delivery, and 54 to 93% of these likely could have been prevented. What exactly is postpartum hemorrhage? It is defined as excessive bleeding following the birth of a baby. About 1 to 5% of women will have a postpartum hemorrhage, and it is more likely with a cesarean birth. Hemorrhage most commonly occurs after the placenta is delivered. The average amount of blood loss after a vaginal delivery is about 500 milliliters, and the average amount of blood loss during a C-section is approximately 1,000 milliliters. The most common cause of postpartum hemorrhage is uterine atony. After a baby is delivered, the uterus normally continues to contract and expels the placenta. After the placenta is delivered, these contractions continue to help compress the bleeding vessels in the area where the placenta was attached. If the uterus does not contract strongly enough, uterine atony occurs. Certain conditions may increase the risk for postpartum hemorrhage. Placental abruption, placenta previa, gestational hypertension, and prolonged labor are just a few. Common symptoms you will see in a postpartum hemorrhage are uncontrolled bleeding, hypotension, tachycardia, decreased hematocrit, and swelling and pain in the tissues of the vaginal and perineal area. So why is postpartum hemorrhage a concern? Because excessive blood loss can cause a severe drop in the mother's blood pressure and may lead to shock and death if not treated. The most common reason that women die from postpartum hemorrhage is because they did not receive early recognition or initiation of effective interventions. What do we, as healthcare providers, need to be focused on to achieve this early recognition of postpartum hemorrhage? The easiest way is to recognize the amount of blood lost during a delivery and directly after. The most common method used in healthcare facilities today is estimated blood loss, or EBL. The method of blood measurement has been used for post-deliveries since the 1800s. The original purpose of estimated blood loss was to determine the need for a blood transfusion. Physicians were trained to visually estimate the blood loss. In the 1960s, researchers began to realize that visual estimated blood loss was underestimated in large amounts of blood loss and overestimated in small amounts of blood loss. However, to this day, estimated blood loss remains the norm for post-delivery quantification. Estimated blood loss is quick and it's easy. However, it's subjective and a visual estimation done by the provider. It has a high rate of error and is not 100% accurate. Quantitative blood loss can be much more time intensive. However, it's objective and quantifiably measured. This results in a lower rate of error. So estimated blood loss continues to be the most common and practical way to quantify maternal blood loss. Because this method is widely accepted, there is little research and agreement on how the situation can be improved. As research continues to develop, healthcare providers need to take the steps needed to implement change to provide a safer labor and delivery experience for their patients. My research was done by searching online resources for research done on my selected topic. My research involved 3 studies conducted between 2014 and 2016. The purpose of all 3 studies was to evaluate postpartum blood loss and the methods of using quantitative blood loss versus estimated blood loss when calculating amount of blood loss during and after delivery. The first article was written on a study done in 2016 on postpartum blood loss and visual estimation versus objective quantification with the use of a novel birthing drape. This study was done on pregnant Thai women ages 18 years and older who were admitted in the early phase of labor. The use of a novel birthing drape was done to effectively measure the volume of postpartum blood loss. This was a sterile piece of plastic that was inserted under the women's buttocks to collect all fluid loss during the third stage of labor. The results showed there was a significant difference in overall blood loss between estimation and objective measurement. The conclusion of the study was that visual estimation of blood loss was inaccurate, which in turn can lead to underestimation of blood loss and a misdiagnosis of early postpartum hemorrhage. The second article was a review of 36 different studies that were done to evaluate various methods of assessing maternal blood loss during childbirth. This review showed that while a small number of strategies did achieve a more accurate estimation of blood loss, none had significant impact on the timing of postpartum hemorrhage diagnosis or prevented the progression of blood loss quantification. However, this study believes that no provider should assume that because postpartum hemorrhage is determined by the amount of blood loss, that a postpartum hemorrhage diagnosis should occur in response to the measured volume. The authors of this study believe that not enough research has been done on the factors that affect decision making during a postpartum hemorrhage diagnosis, and this needs to be explored further. The third article used is based on recommendations from A1 on quantification of blood loss. It addresses the inaccuracy of visual estimation and the implications of inaccurate evaluation of blood loss. The article then discusses quantification of blood loss and tips for healthcare providers to use to implement this into their practice. The research I conducted brought together a main idea that estimated blood loss is ineffective when used to diagnose postpartum hemorrhage. All three articles stated that using a form of quantitative blood loss to obtain exact quantification of blood during and after delivery is crucial in evaluating the diagnosis of postpartum hemorrhage. All three studies also reported better quantification of blood when using quantitative blood loss versus estimated blood loss in their research. The plan I present is directly correlated to the facility I am employed at. Our current practice is that of estimated blood loss until a diagnosis of postpartum hemorrhage has been given. A visual estimation is done by our providers and used to evaluate the risk for postpartum hemorrhage. It is not until there is a suspicion of a postpartum hemorrhage that quantifying blood loss with weighing of pads and material is brought into play. I feel that if our facility were to adopt a practice of quantitative blood loss from the beginning on every single laboring patient, we would provide all cases early recognition and treatment for postpartum hemorrhage. To stay ahead of postpartum hemorrhage, quantification of blood loss should be continuously documented from admission to the end of delivery. This will be done by weighing all delivery materials soaked in blood, by measuring blood in a plastic underbuttocks drape, and by keeping constant record of these measurements. To strive to quantify at every delivery, every person employed in the labor and delivery department should be able to evaluate blood loss and trigger additional action if needed. For vaginal births, an underbuttock drape with a calibrated graduation collection bag should be used for delivery at the completion of the delivery until the completion of the delivery recovery period. All blood clots and blood-soaked material should be weighed to determine cumulative volume. These can be collected during the delivery in a kick bucket located by the provider at the bedside. For a cesarean birth, providers should be aware of the total irrigation fluid used in the OR. There should be suctioning of all irrigation fluid at the end of the procedure. Delivery personnel should weigh all sponges and lap pads, then deduct the weight of dry sponge and lap pads. They should then add the total of amount of fluid from the suction canister. To reach a final number, deduct total irrigation fluid from this amount. Of course, none of this can be done without effective education and participation from all labor and delivery staff. An education simulation will be conducted at multiple times to address all shifts. After the first round of simulations, quantitative blood loss will be implemented with every delivery, and the expectation is that all staff will perform quantitative blood loss on all deliveries. An evaluation will be done by auditing charts for consistent use of quantifying blood loss by all staff. In conclusion, my research showed that there is a need for additional research to be done on this topic. Postpartum hemorrhage is and will continue to be a prevalent issue for women during labor and delivery. A change in policy and procedure will bring a continuity in care that is better for the staff and, most importantly, the patients. Thank you.